hybrid mode, partly. Because I
Such a clear, very excellent. What a presentation. So happy at this particular time where we were just learning about implementation. And this has made me very clear. It almost makes all muscles sound. Thank you so much. We are happy and you're happy.
Yeah, yeah.
Okay, now that is really the terminology is also very. We have joining from the US at an ungodly time, 6 in the morning. Dr. Tina is a little bit cultivated. That's better. Okay. Okay. Dr. Fitzcatello is our director of palliative care at the University of Pittsburgh. And I was very grateful to meet her actually recently at an implementation site workshop we had. And she's done lovely work in the implementation space in the US context. Now, I know we've been talking so much about trying to understand the context and the setting and where you are. And so what may work for St. John's may not work for rural Chhattisgarh or another health setting. And I also wanted Dr. Piscatello to share from her stance, because palliative care is a challenging intervention to implement in any context. And I wanted you all to normalize how the struggle is real wherever you are, and how her work has also demonstrated similar struggles that you have experienced, but of how they have approached it. She is our medical director for palliative care at the University of Pittsburgh and has also a lot of work in the medical ethics space and in caring for seriously ill patients. She is a formidable implementation science researcher and works in the research for the palliative care group as well. And I will hand it over to her to start sharing.
Wonderful, thank you. And I will plan to keep this to 20 minutes to leave time for questions and answers. So first, my plan today is to talk about different interventions that are primary and especially palliative care. The first, I'm going to talk about this integration in the intensive care unit, and then second, talking about goals of care conversations as an intervention in the hospital setting. Just briefly, what is like the difference between primary and secondary palliative care? In the US, how we use these terms is primary palliative care can be done by any type of clinician. So it doesn't require any specialized training in palliative care, but it still focuses on the domains of palliative care, which I'll show you here. These National Coalition of Hospice and Palliative Care guidelines, these are the processes that we should be as palliative care promoting. So talking about physical aspects of care, so like symptom management, pain management, nausea, dyspnea. Talking about psychological or psychiatric aspects of care, social aspects of care, like who's in your family, who's able to take care of you, spiritual, religious, and existential aspects of care, cultural aspects of care, and then caring for the patients nearing the end of life, and then finally ethical and legal aspects of care. So these aspects, they affect any, most clinicians providing direct bedside care. But what the difference is, especially palliative clinicians, they have additional training in these domains of palliative care. So in the United States, people who do specialty palliative care, the physicians, they did an extra year of fellowship to become board certified in hospice and palliative care. So it's just that they, everyone ideally would focus on these kind of domains of care when caring for patients. But the people who do specialty palliative care interventions, they have additional training and expertise in that area. So the first, I'm going to talk to you about a primary palliative care intervention, and then I'm going to move on to a secondary palliative care intervention. These are both research interventions that exist in the US, and then I'm going to tell you about how we kind of using this, what's been done in the past, we implemented something similar to this. So the first was published in the New England Journal of Medicine, and this is a primary palliative intervention. There was not specialty palliative clinicians who are trained in palliative care involved. This was training up the people who already provide care in the ICU settings. So what this intervention did, and this was published by Doug White in 2018 in the New England Journal of Medicine, is these patients at ICU admission, they were the people who were identified as qualifying for this initiative. They would have their first family meeting with the family on day one. And the goal of that first meeting was to do an introduction to the family, provide emotional support to the family, and getting to know the family. On day two, within 48 hours of hospital admission to the ICU, they needed to have an interdisciplinary family meeting. That was like the huge part of this intervention. So they would prepare for this meeting and then have it, ensuring that the family's questions were answered, bringing all the conversation always back to the patient as a person, ensuring that treatment options are discussed, and making sure that there's a great plan for next steps. So that was within 48 hours of admission. And then the next 3 to 6 days that the patient remained in the ICU, the patient would get checked in with daily. The patient's family would get checked in with daily to provide support and answer questions as needed. And then again on day 7, there'd be another interdisciplinary family meeting. So after that first meeting within 48 hours of ICU admission, the next 5 to 7 days, would be repeating interdisciplinary family meetings until the patient left the ICU. So it could keep going on over and over again. And what this study found here, what I want to really point out to you here, so the intervention group had 308 surrogates. This was really focused on the patients couldn't speak for themselves, so it was focusing on their family members. The intervention group had 308 surrogates. The control group had 501 surrogates. The big findings of this study were the quality of life score. There was better quality of life noted in the people who received this intervention. And then the modified patient-centered score, that was also improved in the intervention group. So this intervention did have an impact on these kind of patient-centered measures about how is the quality of communication, how is the patient's quality of life. There was a decreased length of ICU stay. The mean ICU length of stay was 8.1 in the intervention group versus 8.8 days in the control group. And also length of hospital stay, you can see that that was also lower in the intervention group, 11.8 days versus 15.5 days in the control group. So this is providing some really great data about, this intervention that's done by clinicians already working in the intensive care unit setting and interventionalists in the intensive care unit setting can really have an impact on patient care. Now, this isn't a pragmatic trial in that this was being watched very closely. It was an efficacy trial. So there were interventionalists watching to make sure that everything was occurring how it should happen. So it wasn't just standard of practice. It was, this heightened, looking at what's happening with this intervention and making sure that people are doing how it's actually supposed to be done. The next trial I'm going to show you is a trial that's published in Critical Care Medicine in 2019. And this is an early palliative care consultation in the medical intensive care unit, a cluster randomized crossover trial. So this trial is different is that this is specially palliative clinicians, people who are board certified in hospice and palliative care. That was the intervention, it's them being consulted early in the medical intensive care unit. And so in this study done by Jessica Ma, what they did was patients received a palliative care consult from an interprofessional team led by a palliative care clinician within 40 hours of ICU admission. In this study, 97 patients were in the intervention group and then 102 in the usual care group. And when we talk about interdisciplinary palliative care, what that means is it's not just the physician that's involved. It can be nurse practitioners, chaplains, social workers, music therapists, child life specialists. That whole group, that is what interdisciplinary palliative care is. So when we provide specialty palliative care, we really need that full group to be involved. And oftentimes, not all those people are involved in every single patient's care, but that clinician, the physician doing the first initial consult will help determine what additional team members from their team would be best integrated for that specific patient. So what this study found was that there was a lot more do not resuscitate, do not intubate orders in the intervention group versus the control group. So this was really statistically significant. Over 50% of people with the intervention group had a DNR order or DNI order versus only 23% in the control group. They additionally found that the intervention group had significantly more transfers to hospice, 18% versus 4.9%, fewer ventilator days, mean of 4 days versus 6 days, fewer tracheostomies performed, 1% versus 7.8%. And then fewer post-discharge emergency department visits and or readmissions, 17% versus 38%. They found that the operating costs in the medical intensive care unit and pharmacy, they were significantly lower in the intervention group. And then there was no significant difference in ICU length of stay between the control and the intervention group, hospital length of stay, in-hospital mortality, or 30-day mortality between groups. So the super big points I want to point out to you here is that if you look at the inpatient mortality and 30-day mortality, the people that sought specialty palliative care, they did not die more often. You can see here they were more likely to be DNR. They had less, days on the ventilator, less tracheostomies performed. They did not die more often. So these people, they're, from this, what this study is kind of suggesting here is that there are some people getting all these procedures at the end of life, and they are going to die imminently. And these procedures might not actually be like life sustaining for them. And that when specialty palliative care is involved, their involvement is not just coming in and having extra people die. There is no more extra death. They are just hearing from patients and families what their values and preferences are. And a lot of times what they're hearing and what the study is suggesting is that they're hearing from patients and families, I actually don't want this tracheostomy. I don't want to be on the ventilator. I don't want to receive CPR. I still want care. So they're no more likely to die, but they do want, sometimes some of these patients want less interventions done. And that's what this study is identifying here. Now I'm going to move on to a study that's based on that Jessica Moss study, the one I just showed you, that was published in Critical Care Medicine. And this is something that we personally implemented. This study did occur during the COVID pandemic, so that was a little bit more difficult to implement. But this was a true kind of implementation science. We want there to be palliative care integration, especially palliative care integration, into our medical intensive care unit. So this was done at Rush University in Chicago, and it was done in there's multiple different medical intensive care units in that hospital. So the intervention was on one of the units, and then our control group was on the other units that were not touched. That's still the same type of pulmonary critical care physician in charge of the patients. Palliative care could still be consulted in the control group. It just wasn't touched by this triggered mechanism. So the triggers that we used were if a patient met certain criteria, they would receive their attending physician, pulmonary critical care physician, would receive a triggered consult for this patient. And what the consult would say, they would get a page in the morning, and they would say, your patient qualifies for this initiative. If you decline, please let us know. If you don't let us know, then we will plan to see the patient. So that was the intervention. And we also wanted to look at nurse moral distress. In these ICUs, we hear a lot from nurses that, I wish like palliative care was involved. And there's a lot of distress when specialty palliative care is not being involved. So that's what our primary target was to see, does this initiative actually improve nurse moral distress? And then our secondary outcomes were very similar to that Jessica Moss study about looking about tracheostomy use, ventilator use, length of stay, hospital costs. So these are our triggered criteria, and this is really pulled from Jessica Ma's study, what they did in their randomized trial for who met criteria for involvement in that randomized trial. And so here, if you were admitted from a skilled nursing facility or long-term care facility, if you had a diagnosis of end-stage dementia, ALS, Parkinson's, multiple sclerosis, if you had metastatic cancer, if you had cardiac or respiratory arrest with neurologic compromise, multi-organ failure, diagnosis of end-stage cirrhosis, renal disease, heart failure, COPD, and home oxygen. If you were in acute shock on vasopressors for greater than 6 hours, if you had acute respiratory failure requiring intubation for at least 3 days, or if you had a hospital stay greater than 5 days or ICU readmission for the same diagnosis within 30 days. This isn't the exact criteria that Jessica Ma used. We changed it a little bit. One of the things that we changed, for example, was the acute respiratory failure requiring intubation at least 3 days. We made that period longer because sometimes these people admitted for acute respiratory failure, they're like in and out. Like if they have angioedema, they could be in, very quickly and recover and have no real serious illness following that. So we were really trying to target, we adapted these criteria a little bit for our population to really make sure that we were assessing the patients that are most seriously ill in ICU settings. So if you met this trigger within 48 hours of ICU admission, you were going to get that consult placed. And this all occurred in 2020. And so the control and intervention group, I'm going to just show you here, basically these groups were very similar to each other in age, sex, race, ethnicity, vasopressor use, mechanical ventilation use, cancer diagnoses. But the group in the palliative trigger group, 100% of them that we were assessing had a palliative care consult. In the control group, only 26% of patients had a palliative care consult. So you can see here, especially palliative care was still involved in patient care. It's just a ton more often in the intervention group versus the control group. All right. This is looking at the intensive care unit length of stay for the control group and the intervention group here. The axis on the left side is time and days, and you can see here the intervention group and control group, we didn't really impact length of stay at all. And this period, November, December 2020, we were just going into a new wave, our second wave of the COVID-19 pandemic, which a ton of people were just staying on mechanical ventilation for weeks at a time, because they were seeing some people recover after 3 weeks of being on the ventilator. So no impact on length of stay in this specific type of setting. And then, or on ICU length of stay or hospital length of stay is what this is showing here. We did, though, see an earlier time to DNR order. So we were assessing their DNR order status that they wanted for themselves, or their surrogates believe they wanted for themselves earlier. You can see by this graph here for the intervention group versus the control group. So the pink here is the intervention group, and you can see the time and days to a DNR is earlier. The patient outcomes in these groups, we saw, so in the United States, for patients who can't speak for themselves, they can designate someone to be their decision maker. And that's by filling out a document saying, this is who I want my decision maker to be, signing that form, and then they had that form witnessed. If they don't assign a decision maker in the US, states differ in how they define a surrogate for a patient if they didn't legally designate one. In Illinois, there's a surrogate hierarchy. So if you don't have if you didn't assign a surrogate by law, it would be your spouse who makes decisions for you. If your spouse isn't available, it'd be all your adult children equally makes decisions for you. If your children aren't available or you don't have children, then it'd be your adult parents equally making decisions. So we found that in the group, in the intervention group, 100% we had documented who that decision maker was. In the control group, only 61% had that documented. We saw a lot more people in the intervention group ended up going to facilities after hospital admission, 28% versus 14%. And then we also saw, I wanted to point out here, there were some patients, very few patients, but some patients that the physicians taking care of these patients said, these triggered patients, I actually don't think that palliative care should be involved in these patients, especially palliative care. So we wanted to look at who are these people who the palliative care consult was actually declined. So over the study period, we had 6 patients where the clinician declined. And what was really interesting is that the people who were more likely to be declined were people who were more likely to be on mechanical ventilation and people with a very high SOFA score and people with a high length of stay. So these are very sick patients that for some reason that attending physician believed that we should not be involved in that patient's care. Hospital length of stay. So I showed you this between the intervention and control group. We also compared it to a couple other control groups in the ICU setting. And again, the intervention group length of stay, it was 11.5 days. The control groups that we compared it to was 16.6 days, 14.8 days, 22.4 days, and the people that palliative care was declined for. So the intervention group, it had less length of stay. It just wasn't statistically significant here. Now, something that I do want to show you though is that I told you overall, all patients that we were triggered for, there wasn't a decreased length of stay. If you look though at just the people with do not resuscitate orders, so these would be the people that the palliative care came in, the patient or their surrogate decision maker said, them being on life-sustaining treatment, if they have a experience of cardiac arrest, they would want to have a natural death at that point. Those type of patients, we had a significant impact on ICU length of stay and hospital length of stay. So you can see in this graph here on the left in the blue, this is ICU length of stay. The control group, that's people with DNR orders in the control group, and then the intervention group are people with DNR orders in the intervention group. And you can see here, basically everyone was out of the ICU within 20 days if you had a DNR order in the intervention group. But some of the people in the control group with DNR orders, they just kind of hung out around. And you can see the same thing with the hospital length of stay on the left side, the control group, you had some big outliers there, people in the 40 days hospital admission with DNR orders versus the intervention group. If you had a DNR order, you were out of the hospital by day 20. And so the interesting thing here is, is especially palliative care becoming involved, are they helping to identify what are the patient's values and preferences? What other locations would this patient rather be in? They're telling us on our consult, like, I would hate to die in the hospital setting. I want to be at home with my family. They express that the specialty palliative care team is going to move their quickest to help get that patient to where they want to be. And so this is showing that for certain subgroups of patients, especially palliative care, might have more of an impact on their outcomes and where they end up after the hospital. And then this is looking at hospital costs for people who died in the hospital. The intervention group hospital costs, you can see, significantly lower than that control group. So again, no more people are dying in the intervention. It's just the hospital costs are a lot lower. And this is just looking at kind of direct costs, indirect costs, total costs, labor costs, chargeable costs, overhead costs, total ICU costs. Over all these things, palliative care costs were lower for the intervention group. And you can see that very final graph on the side there, that's palliative care's costs. So yes, when you have specialty palliative care being involved, that is a billable charge. But that billable charge is a lot, very, very small financial impact compared to the financial benefit that it can make for the hospital, while just focusing on aligning care with patient values and preferences for care. Um, I told you that we did this study to look at nurse moral distress. High point of this, we did not affect nurse moral distress. There were a lot of things going on here. One of the things is, maybe just specialty palliative care being involved, we're not really doing much to alleviate the distresses that are causing nurses distress. I will also say, I'll point out this graph here. The blue in this graph, the navy blue on the very bottom, you can see from October to January, there's this huge rise in the blue, and that's the huge rise in COVID patients. So we also, when we implemented this initiative, it was on a huge rise of new COVID patients coming in. The hospital, like we had opened up like new ICUs in areas that were not regularly adult ICUs. So the nurse moral distress that we didn't impact it might have been in that context of there's just a ton of new patients coming in, is very difficult. Or actually, maybe we just don't, especially palliative care doesn't impact nurse moral distress, but I just wanted to point that out there. So I'm gonna, I think, stop there. I think the big things that I just want to show you is that primary palliative care interventions and specialty palliative care interventions, they can both impact patient care, both directly patient care, their family care, and then hospital related outcomes as well.
Thank you, Dr. Piscatello. I think earlier today we had a panel discussion where the teams were talking about elements from like the admin side of length of stay and how use of mechanical ventilation and time gets impacted. And so I think you really, through the evidence, have really highlighted how it can or may not, but at the same time, it's really rooted at what we've been trying to say all along, which is what is the patient's value, who is answering, who are we designing this intervention for, and what elements are we bringing to the table as we're co-designing our implementation strategy. So this was all invaluable and helpful as a rubric as the teams here also work on similar projects. I'd like to open it up to the floor for any questions.
Hello, Dr. Gina, this is Sonali here. So I look extensively at quality improvement. So what I'm trying to figure out is how do the two play together? Where does quality improvement come into play and where does implementation science come into play? You have given examples of very controlled implementation research. And prior to this, one of the speakers talked about a more iterative model for implementation research. Could you shed some light on this?
Sure. So I'll say like the first two studies, like especially the first study that I showed you, that was everyone was being watched. There were interventionalists. It was a huge like study team making sure that study worked. I would say the last study that I showed you, and that was like just us doing our trial in Chicago. That was not a big study team. That was just me in the morning. I would look at the patients that were admitted to the ICU overnight, see who met criteria, and then page the team. Nothing else changed. So it was the same palliative care team. The consults would come in the same way as any other consult would come in. So I would say that kind of in that type of a study, that we didn't have much resources, we actually were able to do a ton. And I think it was just really kind of utilizing what already existed within our hospital setting. So our palliative care team within our hospital, we had, I believe, 10 palliative care physicians and 5 palliative nurse practitioners, 2 social workers, um, and that was kind of our big team. But we were, within that group, just new consults coming in for this initiative. We just saw them like we would see any other patient. So I think that was helpful is like that we didn't need this extra interventionalist team. We just utilized what we already had. And I think what happened from that, I can tell you kind of the follow-up of it. So we, saw more of these patients in the ICU who met these triggers. And then we looked at the data from it and the cost data that actually led to hospital administration. They were all on board with this. We had identified that the people in the intervention group versus the control group, how much money we saved over that intervention, we potentially could save the hospital system over $12 million a year just by us seeing these targeted patients. And that led to us, like, we won an award through our hospital for like the best quality improvement project for financial, focusing on like a financial outcome. And that led to a lot more support and resources for us. So I think what helped us was not just, we were just kind of doing our own thing like we normally do, but to be able to look at that data on the back end, that led to hospital administration being like, hey, we actually really need to support palliative care more. They need to be seeing these patients more. Um,
Thank you, that's very helpful.
Any other questions? Again, Dr. Pizzutello, could you speak to some of the barriers and facilitators that you've had in maybe perhaps starting some of these projects or triggers in your system?
yeah. There's usually lots of barriers. There's certain people that like specialty palliative care and other people that I think would just prefer us not to be involved. I think a lot of it is finding out who are your supporters. So for our intervention that we did in Chicago, we had supporters at like the very top of hospital administration. I will say like a number of the clinicians caring for patients in the ICU settings, I think a number of them were concerned about us coming in because they thought, oh, palliative care is going to come in, they're going to take over these conversations. I enjoy doing these conversations. I want to do them myself. I don't want them coming in and like messing things up. So there were definitely people that did not want us involved. And then they could just say to those, triggered consults, I don't want you involved. So nothing was forced on people. They could always get out of it. But I think finding the people, when you have like heads of departments and then like higher than that leadership, just saying that this intervention is going to happen, that makes a lot of things move. So I think that was very helpful. And then basically like the nursing staff of the ICU is extremely supportive. They had their own like palliative care interest group, the bedside nurses, they had formed this group together. And I think like they're kind of banding together and saying, we really want this was extremely supportive. So I think, finding out the facilitators is extremely important. And then the barriers, when people don't want us involved, just, kind of hearing more from them, asking, what are your concerns about us? Because to be honest, I mean, if they have concerns, like we need to be addressing them. Otherwise, we're never going to get involved in that care of the patient. Plus, if their concerns are like they've had bad experiences with our team, we need to like directly acknowledge that and fix that. Um, I think the ideal situation is that when especially palliative care is involved, the ICU team still leads everything. We are just like an additional person in that room for these family meetings to help support the family and make sure that we're kind of doing things, fully aligned with patient values and preferences or care. Especially, there are times where like, the ICU teams, they are just overwhelmed with new patients. They can't possibly have family meetings with every patient. And so there are times where like, especially palliative care, they'll end up doing the meeting by themselves. I think that's sometimes when people get concerned about like, well, palliative care, they're just doing the meeting by themselves. I'm not involved in the patient's, these decision makings, and I don't like as a primary team not being involved in decision making. That can be a cause of like conflict and barrier. But sometimes it's just that the ICU teams physically cannot be there to have these discussions. Like they are just so overwhelmed with other patients. They need like additional team members to come in and help support. So I think sometimes portraying things in that way as well. These people, the data suggests they need to have these conversations within 48 hours of hospital admission to have these benefits of improved patient-centered care, quality of communication. And if you can't provide that care and you have another team that could come in and help assist you with it, and the data says that this would support the patient and their family, why not? So I think find the people who like it, to help support it, and then really using the data. I think that's like the biggest thing that we have, to help promote us is like, this is the data, and if we want what's best for patient care, and this is what the data shows is best for patient care, having these like interdisciplinary family meetings that recur, over the ICU admission, we gotta try for it.
Very well elucidated, and I think highlighting yesterday's talk of rooting our patients at the center and working as a team, as multidisciplinary teams and complementary skills and efforts. Any further questions? Dr. Garrido?
Hi, Dr. Prasidala. Thank you for a lovely presentation. I did have a question. I did hear you say in one of your papers that you talked about nursing moral distress. I had a question about that. I feel like as a part of our framework, we have been talking about individuals and how they can be impactful by implementation of palliative ICU integration. So nurses are the main like people taking care of patients in the ICUs, and they know a lot about their own patients, and they're the ones who can often trigger palliative care consults. I wanted to know from you if you had any success in kind of evaluating that moral distress, or if there was like any follow-up to the nursing moral distress kind of results that came out, or if you've done other research on physician moral distress, palliative care involvement with respect to that, because I feel like that does play a big role here in our institutions as well, and we are trying to empower nurses to kind of trigger palliative care and talk more about it. So any lights that you could share on that?
Yes. So we use this moral distress scale that's been validated. And we found that a number of the things causing nurse distress, palliative care really had no impact on it. So some of them were like additional workload, like documentation workloads, feeling like they're not being heard, things like that. The documentation workload thing, like that's palliative care is not really going to make an impact on that. Some of the things that palliative care could make an impact on are some of the things on the moral distress scale are like we provide care to people who like this is not aligned with their values and preferences for care. So palliative care potentially could make an impact on that. I would say with this study, I really wish we could have just done this without, the COVID impacting it, because I think like some of these nurses were just so like overworked and that they had a lot of distress going on because of that. So after the study ended, one of the nurses that was very involved in the study, who was a bedside nurse in the ICU setting, we actually looked at all this data, and then she had made new interventions, like new wellness for nurses. She got grant funding for this and was able to do these sessions to help promote nurse wellness, talking about distressing cases and kind of like normalizing it, that these are just, these are things that we experience, and how can we like work together as a team to like, do the best that we can for the patients. And I would say also we did these ethics rounds throughout the hospital, focusing on the ICUs, but we did them in other settings as well, where these would be small group settings where you would have the ethics consultants, including myself. We would just sit in a room on the unit, and the nurses could come and talk about their like distressing cases that they were experiencing. And we could just talk out about like, how can we address these things, kind of like potential solutions. And sometimes there are no solutions. Sometimes, we'd hear things about like how this patient's on their deathbed, I'm doing all these interventions to them, it's not going to work. And the family says, I need to keep going. And this is just awful. I think what I'm doing is harming the patient and I'm inducing suffering. And some of those things, like, that's not like that's very difficult to impact. In the United States, like if the family wants certain care to be done, like we usually do it. But I think sometimes kind of focusing on, well, if the patient did want this, even if they can't like express their feelings, there are some people out there that every minute of life is precious to them. And if we're going to honor them, even if you might not see some impact, like they're going to die anyway, could you focus on this is actually patient-centered? So I would say these results that we got were helpful for other types of interventions, but I'm not sure if any of them are really that we did really like impacted all the things that are causing nurse moral distress, which is this measure, this survey that we use, it looked at a ton of different things of moral distress, and we were really focusing on the things that focused on like patient values and preferences. Are we honoring patients as people?
Thank you for that. I appreciate also thank you answered that part of my question, but I also appreciate when you said that we don't need kind of forums or just a space for nurses, or even I guess that can be extrapolated to physicians as well, where it doesn't necessarily, I guess, have to be ethics because yeah, and we could include an ethics consultant here as well, but just somebody to listen to about like patients that we feel guilty about, there is moral distress, and having those kind of debriefing sessions, I feel like physicians, MDTs, nurses in general could really benefit from that. So thank you for talking about that too.
Yeah, no, absolutely. And I think, sometimes like what I've learned is like people just feel more comfortable talking, sometimes in different types of groups. Like, for example, like we heard a lot about how from the nurses that they were very upset with some of the ICU attendings who declined our consults. They just thought that that was wrong, like palliative care should be involved, and why are they declining the consults? They're not telling that to their attendings, they're telling it to us. But sometimes when they, tell it to us in like a safe setting, like we can help, bring that back. But that was a huge barrier. And I think talking about cases too, I remember there was a case where in one of these small group settings, one of the nurses mentioned how she heard from the patient they did not want life support. She heard it directly from the patient. And then the patient decompensated. And by the time the doctors got in the room, they didn't hear that from the patient. So they put the patient on life support. And she's just like, I heard this from the patient and we're not honoring what the patient said because, I heard it. I'm just the nurse. The doctors didn't hear it. I just think like those situations, like what could you do better in those situations? Like all that could have been done better is like the doctor got in the room a few minutes earlier, but who could have planned that if, there's, a lot of other things that are going on in the unit. So it's just like those kind of situations, obviously like no one wants that, but we also have like, laws that we need to follow. And so I think it's nice to have those spaces, is what we heard from the nurses. We did survey the nurses about that and they did like having those spaces.
I think the conclusion is listen to your nurses, but finding space to have our nurses some space to share. Thank you again so much for your time, and especially on such an early morning when she's starting work on the weekend. And we heard from some of the audience, if you don't mind sharing any resources and some of your papers kind of thing this they want to
Before things.
Yeah.
So it's what it is not.
Yeah, I think they're not able to access your full text papers, so feel free to share them whenever is a good time. Again,
Sounds
thank
great.
you so much for your time.
Thank you. Bye.